Greetings, everyone. My name is Karen Carrasquillo. I am the Senior Vice President of Clinical and Professional Affairs at BostonSight, and I would like to welcome you all to our BostonSight SCLERAL Practitioner Learning Series, featuring tonight a webinar titled How to Get Started with BostonSight SCLERAL, Get the Most Out of Your FitKit. With us tonight, we have two brilliant, esteemed, and expert clinicians and KOLs. We have Dr. Suzanne Sherman and Dr. Steve Sorkin. Just, as a matter of a little bit of background, for those of you who may not know these two amazing KOLs, I think most of you by now would know them, but just as a matter of a little bit of background, Dr. Sorkin is Director of Specialty Contact Lens Services at Cornell Associates of New Jersey and Fairfield, New Jersey. He earned his Doctor of Optometry degree from the State University of New York College of Optometry. He participates in many contact lens related studies, lectures extensively throughout the country and internationally on contact lenses, dry eyes, ocular allergies, ocular therapeutics, and corneal disease. He has a special interest in difficult to fit contact lens patients, such as those that we're going to be speaking tonight, like keratoconus and post-surgical cases, and manages patients with complex anterior segment conditions. He also currently serves as the president of the Essex County Optometric Society and is a member of the board of directors of the New Jersey Society of Optometric Physicians. He is a fellow of the Scleral Lens Education Society and adjunct faculty at Salus University. He was actually also named New Jersey Optometrist of the Year in 2018 by the New Jersey Society of Optometric Physicians. Dr. Suzanne Sherman is Assistant Professor of Optometric Sciences and Ophthalmology and Director of Optometric Services at Columbia University Irving Medical Center. She specializes in complex and medically necessary contact lens fittings, anterior segment disease, and primary care. She received her undergrad degree from the University of Michigan with a degree in brain, behavior, and cognitive science. She graduated from SUNY College of Optometry and was elected to the Beta Sigma Kappa International Optometric Honor Society. She completed her optometric residency in ocular disease and primary care at Bronx Lebanon Hospital Center. She is a fellow of the American Academy of Optometry and a fellow of the Scleral Lens Education Society. She is dedicated to research and has contributed to peer-reviewed scientific journals, such as Review of Optometry, Optometric Vision Science. She is also presented in many annual meetings, such as the American Academy of Optometry and the Global Specialty Lens Symposium. So without further ado, I'm going to pass it on to Dr. Steve Sorkin. And while I transfer this to our presentation to presenter mode, I'm just going to let you guys know that towards the end, we will have an opportunity to answer any questions you may have. So if you have any questions, please feel free to direct them through the Q&A panel. And if we have time at the end, as your moderator tonight, we'll try to get to most, if not all, of your questions. So without further ado, Dr. Sorkin, please take it away.
Thank you so much, Dr. Carrasquillo, and thank you to BostonSight. And it's an honor to lecture again with my good friend and colleague, Dr. Sherman. So I'm going to get things started. We'll talk about, obviously, BostonSight lenses and scleral lenses, which is a big passion of mine. I spend a majority of my clinical day dealing with cornea and specialty contact lenses, and scleral lenses being a big part of that. And BostonSight SCLERAL came out about 5 years ago, I believe, and it's become a very integral part of my specialty lens practice. So the original BostonSight SCLERAL came out, again, about 5 years ago with a very large diameter, the 18, 18.5, and 19.0. And we really went to this as our go-to lens for very diseased corneas, very challenging cases. It became really the go-to lens for those type of conditions. But more recently, BostonSight has expanded their horizons a little bit and gone to also having a smaller diameter, which is the 16, 65, and 17.0. So we'll go ahead and talk about those two different categories of lenses and how they play a role in taking care of all of our specialty lens cornea challenging patients. So we'll go through that during the process of this talk. And also we'll touch on a little bit about the Smart 360, which is the freeform and more recent development and kind of where scleral lenses are going. Next slide, please. Okay, so we're going to touch on now what makes BostonSight SCLERAL so special, that it has many built-in features that allows you to be very precise and very successful in fitting a lot of these type of patients. So really the knowledge and experience that goes into the design of these lenses, the ability to customize the lens as you need to, makes for a very, very successful type of lens. Next slide, please. Okay. The real amazing thing about BostonSight SCLERAL is that when they did the original data for the lenses, they found, and we found, that there is definitely a difference in anatomical shape between the right eye and the left eye, and that has to do with EOM insertion and just the overall shape of the sclera. So when we're fitting scleral lenses, of course, we are fitting the sclera as well as the cornea. So the data has gone into this design, has allowed us to be able to do a more specific right and left. So I believe it's the only scleral lens design that I know of that actually addresses this difference. So when you're putting a right lens in versus a left lens is obviously very critical, because there's definitely differences in how that lens is going to perform on the eye. So when you look at the fitting set, and Dr. Sherman will go over that in a few slides, you'll see that there is a right side and a left side, and all the lenses are marked R and L. So this is a very critical part of the design and fitting process. And it's very important that you stick to the right eye or left eye. Next slide. So one of the other main things that BostonSight has allowed us to do is do quad-specific haptics. So the lenses that you get in the fitting set, all the lenses already have built-in quadrant haptics. A lot of designs will come with toric haptics, but this has built-in quad haptics. So there'll be a 1, 2, 3, and 4 marked on every lens. That'll orient you on which particular area you need to address. So you can address those all together or independently, which makes it a very customizable design. Okay, so quadrant specific is built in, it's automatic, that's the way the lens is designed. Next. And the other thing that's been added in more recently is having oval optic zones. We know that the corneas are not round, they're oval. So the idea of having a more customized design built into the lens allows for better stability and improved centration, and also allows for the ability to eliminate certain things like conjunctival prolapse and certain types of centration issues that can happen with other designs. Okay, next slide, please. And here's another really exciting area of vision correction part with the BostonSight SCLERAL. We talked about the fitting characteristics, but also the other part that makes BostonSight SCLERAL shine is the ability to have built-in eccentricity. And we'll talk about that a little bit later on, particularly in my cases. So if you look at the two different visual acuity charts there on the bottom, courtesy of Dr. Gomez, on the left there is just a traditional scleral lens, and you can see all the ghosting and coma with that lens. 90% of the fits achieve optimal vision with the built-in front surface eccentricity. And there's 0, 1, and 2, which we'll go over a little bit later on. But you can see the increase in quality, and that's built into the lens. There's nothing that you specifically need to do. So it does improve quality of vision. My case that I'll show you later on was just like this. We had a patient that was wearing a scleral lens from another office. We refit them into the BostonSight lens, and they had a significantly improved. Number one, they saw it better on the chart, but number two, more specifically, they said that their quality of vision had never been better. So we really can change the lives of our patients, and sometimes doing things like changing the eccentricity can be very effective in changing that quality of vision. Next slide, please. And this is really another exciting area that's happening in scleral lenses, and that's the ability to customize the lens and incorporate higher order aberration correction. So this is something that is being discussed and studied, and BostonSight has the ability now to incorporate these type of corrections into the scleral lens, and that's called the SmartSight HOA. And that's not in the original fitting set, that's a little bit more advanced. Next slide, please. Another design feature that's been added to the BostonSight lens is the ability to add what we call channels or smart channels. And that's an area that you can add to the periphery of the lens that will allow increased tear flow under the lens itself. So number one will allow certain, what I call speed bumps, which is like pingueculas, pterygias, or Salzmann's nodules, things like that, where you can basically, leap over those areas and make the lens more comfortable and less issues with physiology. And the other part is to reduce suction. So we have patients, particularly those who, let's say, have a corneal transplant and you want to have more tear exchange or allow the lens to not suction onto the eye quite as readily. This smart channel allows you to do that. So really the main thing we're doing is promoting tear exchange and also improving both the quality of comfort for the patient, as well as also the visible redness and irritation and injection that can happen with lenses that do not have the smart channels. So this is another added feature that's available with the BostonSight SCLERAL. Next slide. And then another area that is very exciting now is the ability to measure and quantify not only the cornea, but also the scleral with scleral topography. So there are two different versions, the eaglet and the Oculus Pentacam CSP, and those things can be incorporated into your practice, and they allow you to do what I said before, which is more of a free-form design, which is even a more customized lens rather than doing diagnostic lenses. So this is available in 16 to 19 millimeter diameters. Okay, next slide, please. And what's really nice about the BostonSight people is that you have the ability to connect with consultation and also the ability to order lenses and check on the status of lenses online, which is what's called Fit Connect. So if you have an account with BostonSight, they'll set you up with this and you can go online. And it's really nice because you can customize the lenses, make changes. There's ways to do it. And then if you do need consultation, of course, you have that ability. So you can do things like design lenses using graphical analysis, place orders, track shipments. You can check your invoices, check your bills, print prescriptions. So it's really helpful. I find that it's great to be able to do that online, saves time, and it's very easy to access as well. And BostonSight has recently changed their warranty period as a point to 120 days. So it's unlimited returns within 120 days. So if you do have a very difficult fit, or you're just getting started, you feel like you need that extra time, it's really great to have a 4-month window to be able to make adjustments and changes. So that's very helpful. Okay, next slide. Okay, so this is just a graphical analysis, actually a representation where when you do go onto the Fit Connect, obviously you can send notes to the laboratory people and they will go ahead and take that information, and that's called hold for consultation. So you just click on that area there and it's very helpful, and they will contact you to go over the case, or you can call them by phone, obviously. Okay, next slide, please. Okay, so these are the superstars behind the scenes. And we have Chris Nicholson on the line. He's the newest member of the team. And Manny is in charge of the lab itself. So these are really great people to have on your side if you do need help, either via email or you can call into the lab itself. So always utilize your consultants, and BostonSight has a great team, like I said. So, if you do have a question, they can walk you through what you need. You can email them, scans or photos, videos, and also to, just to discuss a case if you need to. Okay, so I'm going to hand it over now to Dr. Sherman. She's going to go over, take it away.
Thank you, Dr. Sorkin. So first of all, thank you to BostonSight for having me, and to Karen and Steve, two of my mentors. It's really an honor. And to see 70 of you on here tonight, it's Tuesday night, 8 o'clock. I'm impressed. Hope your kids are sleeping. You've got a nice drink, cold beverage. And actually, as I scroll through the list of participants here, it's kind of fun. We have people from Ecuador. I see old classmates, some very good friends who I've lectured with, and I have to give a shout out to my own father who has decided to participate, even though he is not an optometrist, ophthalmologist, contact lens fitter, more of a OBGYN. So thanks, Dad. So we're going to get started. I really liked this graphic because when it comes to scleral contact lenses, we think of bowls, right? And so we have the fish and which size is the right size. And I think the key to BostonSight and specifically this scleral lens they've created is that it's really intuitive. And they've taken a lot of the complex decisions out of it, and they've really given you such a sturdy data-driven lens that you can fly. So we're going to walk through where you would start if you're new to the fit, or if you've been fitting for a while, but you're new to BostonSight. So there's two different fitting sets now. And when I first started fitting this 5 years or so ago, we didn't have this. So this is really exciting. Just in two separate sets, you have diameters from 16 millimeters all the way to 19. And what I would say is that if you don't have a lot of sets in your practice, or you're just getting started, you don't need much more than this to at least get started. One set has 16 millimeters, 16.5 and 17, and the other has 18, 18.5 and 19. And that really covers almost all of your bases. I know Steve very well, and I know he has fit some smaller lenses than this, and I myself in my practice have some larger than this, but this is a wonderful, very well-rounded place to begin. So starting with the 16, 16.5, 17, who are the patients you're going to put these lenses on? You know, one thing that people use is HVID, horizontal visible iris diameter. And if you're not familiar with that, you haven't measured that before, any conference you go to, they will give you multiple of these rulers. I used to shove my pockets as a student, anything free, right? So you can pick those up. You also, when you do a pentacam or any kind of topography or slit lamp camera, you actually can measure the iris diameter on there. So the suggestion is less than 11 millimeters. Small apertures, tight or taut lids, regular corneas, pediatric patients, and patients who have poor dexterity or a large lens would seem difficult. This is a good place to start. When I first started fitting lenses, a colleague of mine actually suggested, you turn the patient to the side and you with your own fingers, you kind of open up their eye. That gives you an idea of how taut the lens is and how wide their aperture is. And the larger ones, 18, 18.5, 19, larger HVIDs, 11.5 or larger, compromised ocular surface. That makes sense. You want to cover as much of that surface as possible. A highly ectatic cornea, if you think about having to climb over a hill, if you have to get much higher up, the landing won't be as steep if you have a larger surface area to come down on. Chronic exposure, we want every area of the eye covered. Compromised or fragile grafts. You might not think that that's a large diameter lens, but in these patients, we often want a really loose fitting lens. So there's really no suction when the lens comes off. And severe dry eye, similar to the other ocular surface disease ones, we want to cover the ocular surface to the maximum capacity. So when you get your fitting set, this is a very simplified version of their algorithm. And as Steve said, we have one for the right eye and one for the left eye. And I can't tell you the number of times before I got this set that I either had to take the lens off a patient's right eye to put it on the left eye because I wanted the same lens for both eyes, or I had to compromise in going up and down, or not the exact lens I wanted because I needed the exact same lens for both eyes. So here we go. We have a set that has a right and a left, which is really wonderful because they've taken into account the extraocular muscles and the ways that our lenses decenter. We know they decenter temporally and slightly down. And this has all been put into these lenses. So when you open your set, regardless of the diameter, you're first going to start with your standard lens. And this is the light blue kind of teal center dot here. And every lens on that horizontal lane will all be the same sagittal height. And you're able to pivot based off what you see when you've put that first lens on. So if the lens is too loose, you can move to the right and go to a steeper distribution, which means the edges would be steeper, but the sag stays the same. And if I've learned anything in the last, almost decade of practicing, is that I like to make one change at a time, because if you make more than one change, you either create a problem and you don't know what caused it, or you fix a problem and you don't know what fixed the problem. So the nice thing is this lens just changes the edges, or if the lens is too tight, you can make it looser by making your edges flatter. So this is a very simplified version of what you will see in your fitting set. And if you're just starting, this is a great place to just pinpoint in the center, and then you know to move to the right or to the left. So this is a setup of what the fitting set would look like. And this is just one eye. And this happens to be the larger diameter fitting set. So the 19, the 18.5, and 18.0. And what I will tell you is that I often start at standard, and I don't usually end up pivoting to the right or to the left at this point. And that's because based on what I see from the standard lens, I know if the sag looks good, and I know if I see flat or steep edges, and I know what I'm going to change without having to take off that lens and put another one on. However, in the beginning, when you first get this set, this is a really great way to teach yourself, either on a colleague or a technician, is just move up and move down, move right or left, and see how the edges change. But you see that the sag stays the same. So you're only changing one parameter, and this makes it so you can really observe what happens when you change the haptics. Now, the other thing on this fitting set you'll see is that there also is a steeper sag, so you can have even more clearance, and it goes up to 3.4 sag, and that's to the right. And why is this really important? From getting burned multiple times, I'll tell you that it is much easier if you have too much clearance to know how much to bring the lens down. Why? We know lenses are around 300 microns thick. So we can compare that to the tear film, and you can make an educated decision on how to change your fit. But when you fit a lens and you're touching, it's really, really hard to know how much you have to increase that lens in order to clear the cornea. So I have countless times called Manny and said, what do you think? This many, and together we try to make an educated decision. And I would tell you, sometimes we do wonderful and sometimes we don't. And you'll have to see with your own comfort level. I'm at a place where if there's a tiny bit of touch, I will often let the patient go home with it and mail them a new lens. But that's why BostonSight has created it, so that you can always move up, but you're not really moving down, because you always want to be fully clearing it. Now we're going to move to this gray box on the side here. And this is something that Steve mentioned. This is really incredible technology. And this is front surface eccentricity. And you have options here. In my practice, I probably will tell you 9 out of 10 times I don't utilize this. Now, maybe I'm underutilizing it. And that's because the lens is so good that I feel it's not always necessary. But when you do utilize it, it's really exciting. And we use this when we have a patient that we either refracted, or often in my practice, I'll throw an RGP, a corneal RGP on, and you expect better vision than you got in the scleral lens. So if the patient has an irregular cornea, and the initial lens you put on, it's an front surface eccentricity of 1, you would go to the FSE 2. That's the recommended change. And if it improves the vision, then you will order your lens with FSE 2 on it. Now, if you look at the numbers, the sag is the higher sag there, and the curvature is going with the standard curve. I mean, the landing is standard. So those are little things to keep in mind. Now, if you're fitting a normal cornea, someone who just has dry eye, and again, you're kind of wondering, why is the vision not better than it should be, you would go to an SE0. And the nice thing is you have these lenses in your fitting set, so you can always throw them on and see if you get improvement or not. And I think we have a little video now that you can actually see where online in the Fit Connect, you can actually make these parameter changes. So the person is ordering, they're putting in their prescription power, and then if they had cylinder and axes, but here they says Smart Sight FSE, and you pick 1, 2, or 3. If you're not changing it, it automatically defaults to FSE1. So what's the benefit of having this wide range of data and driven diameters with built-in scleral shape? I would tell you the benefit, I think, is that in my opinion, sometimes mostly less is more. And what I've learned is less manipulation is beneficial, and especially when you have a really smart lens. But also they have something called Smart 360. If you're lucky enough to have an eaglet or a surface profile or the Oculus CSP, you can do this in a design-free form using a 360 scan of the eye. I haven't had the privilege of doing that, but I have some colleagues who have and really enjoy it. Right. So, what's the benefit of this? We know our patients really well. And the more you get to know your lenses, you will know what the best lens for them is, and you'll know how to walk them through them. And with the different parameters and the different sags, you're able to kind of move around in a way that benefits your patient. So I'm going to walk you through a couple of my patients. And I want to give this disclaimer. These patients, when you see the case and what they actually have, the underlying pathology and disease seems very complex and severe and might not be the kind of patient you have in your chair. However, the fit is not. So it's easy to be intimidated in the beginning by the underlying pathology, but the actual act of fitting and benefiting the patient is something everyone can handle. So this is a patient who has CPEO. This is a mitochondrial disease, and they have severe ptosis. You can see on the left, you can't see their pupillary reflex. This is a 20-year-old girl, 20/20 vision in both eyes, has tried ptosis crutches, has tried taping her lids, but she has severe dry eye. With CPEO, you often cannot move your eye muscles. So your eyes are fixed in place, and so she can't block her eyes from wind or shield. So we actually used the diagnosis of keratoconjunctivitis sicca to submit to her insurance, and she was cleared for scleral contacts. And I knew in this case, I wanted a large diameter lens. Why? I wanted to cover the largest surface area of the eye. Also, I knew that this was a healthy cornea, and I had the ability to put excessive amount of central clearance to get the lids to rest on the lens. So I can manipulate the amount of central clearance to make the lens even further from the cornea to get the eyelids open. And you see here, she has about a 3 millimeter improvement. She's now been wearing these lenses for 3 to 4 years. She does wear glasses on top. This was a first lens fit that worked perfectly. She saw well. We didn't change it for about 2 years until we even made it more clearance so that her lids were up even more. And this has been a huge quality of life change, but not something that took a tremendous amount of my chair time. It was really incredible. This is another patient of mine. I actually saw him today. He's lovely. He had squamous cell carcinoma of the maxillary sinus, orbit, skin of the left cheek. This has left him with lag ophthalmos of the lower lid, and he also had radiation therapy. I have a good amount of patients who have had radiation, as we have ocular oncology at Columbia. And these patients have severe ocular surface disease. His case, the eye doesn't close at all. And when he came to see me in probably 2018, 2017, he had tried every bandage contact lens possible. And this is a case where I started with an 18 millimeter lens. And at the time, that's the only one I had from BostonSight. I let him go get a coffee with his wife, and he had such tremendous relief that I actually let him take this lens home with him that day. And over time, we increased the diameter of the lens to cover even more surface area to 19 millimeters. I do note that he has a subconch heme in this picture that is not from his lens. This just happened to be the one we captured. And in his case, he's unusual in that with the clearance of his ocular oncologist, we actually have him in a scleral lens, large diameter, 23 hours a day. So he has 2 separate lenses. He alternates daytime and nighttime. And I saw him today. He's been wearing about 4 years straight, and he's doing phenomenal. His vision is 20/20. The cornea looks pristine, and he has no reoccurrences, which is really incredible.
Sure, Sherman, just a quick question
Sure.
about that. What was the scleral shape that you actually used to fit this patient out of the standard, steep, or flat?
So I'll tell you, in my my opinion only. When I first started fitting, I did a lot of small and tight lenses, and I have evolved a lot in that now I do a lot of large and loose lenses. So I almost never start steep. I always start standard or loose. And the reason is a lot of my patients are ocular surface disease patients, and I don't want any suction when the lens is removed. So in him, I put a standard on, and over time we may have loosened the edges.
Well, that's great. That's good to know. So, I mean, in a way, the standard is the go-to. So that's great to know. Thank you.
Yeah, I've also, at this point, I want to spend shared time with my patient, but not changing lenses over and over. So the standard gives me the ability to know if I need to move right or left. And I like that.
Wonderful. Thanks.
And this is just a side view. You see his lower lid really is not, and this is a young guy. And you see that he's already been through extremely traumatic surgery, and his face is severely disfigured. And before, he was wearing a patch all the time, and he's in hospitality. So this is a life-changing medical device that, from a fitting perspective, was actually fairly easy, but could have seemed really intimidating. This is another patient of mine, and those on the call, or Steve will tell you, I'm a bigger is better kind of person at this point. I did not start that way, but this is the case where a small lens really can do a lot of good. This is another patient of mine with basal cell carcinoma of her left eyelid, and you can see if you look closely, she has these dagger trichiasis lashes coming down. She's had a skin graft. She has Salzman's nodules from the area just being chronically exposed, which led her to get a herpetic infection. But she still has about 20/30 vision. She had tried multiple bandage contact lenses. So when I looked at her, even though my normal reaction is go big, I said, I don't think that's a great idea this time, for a couple of reasons. One, you see the area where it almost looks like she has a symblepharon, the conj and the lid have really kind of grown together. Two, you see her lids are taut, they're uncomfortable looking, they're angry. She's going to have to be using her fingers to manipulate them to get a lens in. So in this case, I ended up going smaller, and for me, smaller is 17 millimeters. And this is another case where we did a 17 millimeter lens because it covered almost her entire ocular surface. It did not interfere with the symblepharon area. And she is now wearing the lens about 14 hours a day. And she will be another patient that's using it twice, two different lenses, one for during the day and one for at night. But it is another patient of mine where I really did not have to do tremendous manipulation in order to get the lens to fit well and for the patient to have good comfort. Ooh, I think
it's my turn. All right, so thank you, Dr. Sherman. Wonderful cases. Now I'm going to go over a few of my cases. And let's start with, and I echo what Suzanne had said, we're going to show you some cases that are pretty challenging, possibly, but I want to demonstrate number one, the utilization of scleral lenses in general, but specifically the BostonSight lens, to allow us to fit these patients effectively and quickly without having to make multiple lens changes, orders. So just the straightforward nature of the fitting set and how to incorporate what you need to with minimal changes. So this, my first case that I'm going to discuss with you is a patient of mine who was referred by a cornea surgeon. He was doing some work around his house. He was decided to pull off some siding off of his house, and a nail flew right into his cornea. And being like a retired fireman, he decided to try to pull the nail out himself. And once he started seeing fluid draining down his cheek, he decided to go to the ER. And the cornea service there, patched him up, and he ended up having a huge full thickness laceration, so full and a ruptured globe. So thankfully, the retina was intact. They had to remove his lens, aphakic. So he came to see me about 6 months after the accident, wanting to be fit with a scleral lens. So you can see that he was 2400. He penholzed about 2060, being aphakic. Left eye, he had a mild cataract. That's just topography there. You see that very irregular cornea. This is very, obviously a very challenging case. Next slide. So that's just photographs of his laceration. You can still see there are 4 sutures still in place in the center of the cornea. So I looked at this and said, wow, we need to go to a large lens. We need to clear that area. I don't want anything touching the cornea. A lot of times in aphakic patients, I like to do corneal GP lenses from a physiology standpoint. However, in this case, looking at that cornea, looking at the sutures still being there really was not a good idea. I knew scleral lens was the way to go. Next slide. So that's just his OCT. You can actually see the sutures, those lines there. You can actually see them. Right. Thank you, Karen. Those are the the sutures still in place. It's got a very irregular cornea. You see the laceration went through the cornea itself, and you don't see a lens there in the OCT as well. So we decided to go with a large diameter. I did an 18.5. We did the standard shape and the FSC1. So of course we got a huge hyperopic overrefraction, got him to about 2050. We looked at the lens. It was fitting about 350, which we know a scleral lens, of course, is going to settle over time. And I was actually okay with leaving it a little bit higher than normal, just because we wanted to stay away from those sutures and that corneal scar that's there. So I looked at it and said, all right, well, 2050, let's put another lens on. And then we ended up putting on the E2. And look at that, we got from a 2050 to 2040 plus, so almost a 2-line improvement. So just showing the quality of vision. The patient was very motivated at that point. We ordered the lens. We obviously had to be conscious of, we don't want too thick of a lens because of the high plus power. So we ordered that lens for him. And next slide. And we ended up having a lens that was 20 volt of 300. Everything looked good from a fitting standpoint. We did get a plus 0.75 overrefraction with the first lens we ordered. So I figured, let's get him started at least on this lens, send him home, ordered the other lens with the plus 75, came in for his follow-up visit a couple weeks later, doing really well, wearing the lens 12 hours. Cornea looked good, no stain, very happy. And we ended up just switching out the power, and the patient ended up doing really well. So other than a power change, which I consider not really a big deal, he ended up doing really well, very successful. So he now can see out of 2 eyes rather than 1, and he's very happy, and we're very happy. So nice and straightforward case, even though it's a very challenging cornea. So we use a large diameter lens in this case because of the corneal pathology. The idea is a larger lens will clear that area better, stay away from the sutures. And then we have incorporated that FSC2 in a patient that has a compromised cornea and aphakia, and that allowed the vision to be improved about 2 lines from switching from the built-in FSC1, which is the standard lens that's used in the fitting kit, over the FSC2. And basically we reduced HOAs and improved vision quality, and obviously made a huge difference in this patient's life. Okay, I'm going to move on to an ocular surface case, which is a neurotrophic patient. This is a patient that unfortunately had cancer, had multiple radiation treatments, and ended up having a neurotrophic ulcer. Again, cornea had the patient for a while, tried multiple treatments, amniotic membranes and oxyrvate, all kind of lubrication, steroids, everything. And unfortunately, the patient just could not get healing. So the patient was referred to me for scleral lens. In addition to her cancer radiation, she also had eyelid keratinization. So she had surgery for that. So not only does she have corneal disease, but she also has eyelid disease. So I looked at this case and said, scleral lenses can be helpful in this, but we're dealing with a patient who's had multiple lid surgeries and radiation. I think going to a smaller lens in this case would be a good idea. Plus she had an HVID of 11.3, which is very much on the small side. There is a topography shown there. Again, with the cornea being the way it is, it's not hugely valuable to us, but it's nice to be able to see what the topography looks like. What we're seeing as we're seeing her back for follow-up visits over the last few months is that that topography is more regular now as her cornea is healing. So she's 2200 in that eye, of course, because of the corneal pathology. Okay, next slide, please. And we used the 16 millimeter, which is on the low end for the BostonSight. And I started with the FSC1. She was also a hyperope as well, so she's about a +4. So it wasn't unusual to get up, a high plus overrefraction. We got her to about 2060. But again, she's not going to be anywhere near 20/20 looking at that cornea. So the idea at this point is more of not only vision correction, but more importantly, it's treatment of an ocular disease and healing. And that's what a wonderful thing a scleral lens can do. Those of you who do scleral lenses now, you know that obviously they're life changers, that not only do we correct vision in a lot of patients, but also we are able to heal various corneal diseases as well. Okay, so again, we got to about 20/50. She also was one of those patients that took at least an hour for her to even get the lens in herself. So my technician and extern were extra patient with her, but she was able to do it. She went home with it. She left with the lens. We saw her back for a couple of weeks later. Next slide. And again, she came back from multiple follow visits. Her cornea looks a whole lot better. The last time I saw her, which was last week, she was down to about 20/30 minus. So her cornea is healing. She's doing better. And this has been obviously a long-term process. And when you're dealing with these type of patients, it's obviously not just fitting the contact lens, but managing their corneal disease as well. So she's doing well. She's down to 20/30. She's wearing lens 10 hours a day. We're happy. The cornea specialist is happy. And she's doing well. She can get the lens in now in 1 or 2 tries, no problem. So the idea of using a smaller lens for a patient who, in most cases, you go with a larger lens, as Suzanne had said earlier, but sometimes you have to switch gears based on anatomy, based on dexterity issues. In her case, being smaller aperture with lid condition that prevented us from going with a larger lens. So the nice thing to have with the BostonSight is now having that smaller lens diameter for these type of patients. And one lens and we were done. Another really straightforward case where we reached for one lens, put it on, and we ordered it, and the patient is doing great.
That's amazing.
Next slide, please.
Dr. Sorkin, before we go to the next slide, I just wanted to mention there's a few attendees that have been raising their hand. I would imagine to ask questions, but we'd like to encourage them to just write your questions in the Q&A panel. And at the end, hopefully we'll have time to address your questions. Thank you. So let's move to the next slide here.
And as I said, small aperture. She also had a small HVID of 11.3, and the idea of having that different, from 16 up to 19, to be able to handle just about every patient. And this is a now keratoconus patient. Let's talk about what we mostly see. Was a patient who has high drops in the other eye, so they're not even interested in doing contacts. So I inherited her from another practitioner who had retired. So he had done some scleral lenses, and he had referred the patient to me. I took on her care, and she was wearing a scleral lens. She was doing very well. Her current lens was 3 years old. She hasn't seen the doc in a while. She was happy with the comfort, but she said, as a lot of our patients do, can you get my vision any better? Especially keratoconus patients are always looking for that perfect 20/20 vision, where we know a lot of them unfortunately can't get there. But she was motivated. She was seeing about 20/40 with her current scleral lens, and she had a 12.3 HVID. And we said, hey, this lens you have is fine, but there is other options. We have newer technology now. Let's try this this BostonSight lens, which has the ability to address the hydroorder aberrations. Okay, so next slide. And you'll see our topography. This is just a traditional keratoconus patient. So there we go. So the Ks are high 50s, low 60s. Again, the 12.3 HVID. So the cornea is on the larger side. So we're definitely thinking of going with a larger diameter lens. So I ended up going with a 19 millimeter lens, and we went with the FSE1, which is a standard lens that's in the fitting kit. They got just a -125 overrefraction. I don't know about you, Suzanne, but a lot of my patients, because of the FSE, a lot of patients don't even need a huge overrefraction. I think, the lenses, maybe 1 or 2 diopters in a lot of cases, unless they have, obviously a phakic or something like that, a very, very high myopia. I find you don't have to go to very high powers in a lot of cases, which is also very helpful from a physiology standpoint, as well as just a curvature standpoint. I think leaving the lens without doing those high powers that allows the vision to be better quality. The tear layer is more uniform. So, getting back to this patient, just a minus 125 over-refraction, she went from remember 2040 from her previous lens down to a 2030 plus 2. And she, the lens fit well as it should. And we ended up getting her about to 2025 with the lens that was ordered. So she did really, really well. And I actually just saw her last week for her 6-month follow-up. And she said to me, doctor, I'm just so impressed with you. You got me fit in one lens. She lived an hour and a half away down the Jersey Shore. So not like she was around the block. And she was just so happy that we were able to fit her in one lens. And number one, she said, just the ease and the smoothness of doing this. Plus, she's obviously very appreciative that we were able to get her vision quality better, which was definitely noticeable for her and for us as well. So another happy patient that we have with BostonSight lenses. So I hope some of these cases that we presented today don't scare you off, but make you hopefully get motivated to if you don't have the fitting set already, to get started. If you do have the fitting set and you're not doing a lot of them, jump in. The lens kit is just so intuitive, and it just makes it so much more straightforward for you to, just jump in, get started, put some lenses on, get some experience doing it. And BostonSight, the consultation team is available for you. And of course, I'm available to you as well, and Karen, if needed as well.
Yeah, I have to agree with Steve in what he just said. I have a very distinct memory of maybe 5 or 6 years ago calling Karen for help on a fit, and she FaceTimed me in the middle of the day, and she had a pad, and she literally was holding the pad like this, and she was drawing how the lens moves and changes, and she had no problem being really selfless with her time. And she also let me come to BostonSight and spend a day with her. And Manny has spent way too many hours on the phone or emailing with me. So I think the support is really incredible. And I would also say those of you who have students, or like in our practice, we have ophthalmology residents, and also really educated, smart technicians who are NCLE trained. This is a great learning lens because, as Steve was saying, you often don't need a huge amount of power on the lens. So the effect of the lens is obvious very quickly. You get a lot of wow factor, and a lot of the troubleshooting is done for you. So you're kind of playing a more simple game because you're using a smarter lens. And also I want to agree with Steve that if you have questions, I think any of us are available and would be happy to help. I call both of these two incredible optometrists often with questions. So.
Thank you. And I'll say that there's so many times where we put the diagnostic lens on and it's so close that patients beg me can I just take this lens home? It's so much better than what I had before, or so much better than when I walked in here today. So it's tempting. You just want to say, oh, well, we have to order a lens for you. It's not exactly where we need to be, but it's just amazing how many times I've gotten that with this lens, for sure.
That's amazing. That's just great to hear. I think that's just a testament of, the power of data and these data-driven lenses. So that's fantastic. With that, I think, we're coming to the end of our webinar, which is good because we have about 10 minutes or so, Steve and Suzanne, and there's some questions in the Q&A panel. So let's just get to them. Dr. Luciano Bastos, I believe he is from Brazil. Welcome. Do you compensate on other areas like central base curve to maintain the same sag, changing the landing zone? I'm going to jumpstart with that answer, and then please chime in, both of you, with your experience. I would love to hear your experience. So one of the great things about BostonSight lenses, Dr. Bastos, is we have the benefit of spline curve technology, And that allows us to manipulate the lens design and the parameters independent from one another. BostonSight SCLERAL is a lens design where the base curve is decoupled from the sag. So the base curve, in essence, what's doing in this design is actually modifying the peripheral cornea into the limbal zone, where if you flatten the base curve, you're increasing that clearance in the periphery. And if you're steepening the base curve, you're decreasing the clearance in that periphery. But then you can adjust the sag independently. And when you raise the sag or lower it, that's independent from actually the landing zone. So you can have that parameter independence. So that's actually a real benefit. I actually enjoy that coming into clinic and offering pros treatment for my patients at BostonSight. What has been your experience, Stephen and Suzanne?
Yeah, agreed.
Yeah, I would agree. And I also think when you're first fitting, or even now for me, changing multiple parameters at the same time, it complicates things because you don't know what works and what's not working, or oftentimes you create your own new problem, you know, when we're trying to go for perfection, right? So taking it one step at a time and that one change not causing everything else to change is actually it gives you a ton of good information. So I actually think this is a huge benefit of the lens.
That's wonderful. There's a question, same Dr. Bastos as well. What are the difference between daily wear and sleeping time? I know you commented on that, Suzanne. Please chime in, and then I can also chime in afterwards.
So I think that's a tricky question. In the literature, there is not much data about this. There are some, I think, 1 or 2 case reports, and it might even be from BostonSight. Karen probably wrote them. So I have looked into this a significant amount. What I would tell you is you have to walk before you run with these patients. You slowly build up to make sure their corneas can tolerate it. In my case, I'm very lucky that I am co-managing them with either an ocular oncologist or a cornea specialist on the floor with me. And we don't start this way. We start with building up the wear time during the day. And we always ask that they have, you know, at least an hour of time off. I know this is very hard for some of these patients. And now this is not evidence proof or research based, but I personally am in favor of having a different lens for night and day, or just having 2 separate ones. So you can really do a thorough cleaning when the other lens is off. But there isn't a tremendous amount of the literature about this. And I think Stephen and Karen can agree. I do have a handful of patients doing it and doing it well, but these are also people that we watch very closely.
Yeah, I think that's the key. So I think it's important to note that in the United States, so these designs are cleared by the FDA, and the clearance is actually for daily wear. Like everything in healthcare, medicine, optometry, when we practice and we manage our patients, we have to do so understanding what are the approvals, but sometimes these practices, something that Dr. Sherman has shared, these would be considered off-label uses of these lenses. And oftentimes, you know, the way we do this in our clinic, there's an informed consent process where we educate the patient about the benefits and risk, and the patient agrees to move forward. And I think that the key, obviously, besides educating the patient, is what Dr. Sherman is saying. Knowing that this is off-label uses, sometimes these patients with ocular surface diseases, they just need this. They've tried other alternatives, and this is what they need. The key is that you have to do this very judiciously and monitor these patients so closely, because obviously there is a risk for infection when we have patients sleeping with lenses. And if we do so, obviously the management and care that we take is hopefully, you know, obviously geared towards preventing and mitigating those risks. And I think, Suzanne, that's why I totally appreciate what you're saying when you're saying that you're co-managing these patients in the medical center where you practice. We have the fortune to do the same thing in our practice with our corneal specialist. So I hope this answers the question, Dr. Bastos. Thank you for joining from Brazil. Dr. Babasquez, who's actually joining from Ecuador, welcome as well. He's asking, should we always orient these lenses when we apply them at 12 o'clock? Or is it not necessarily the case? If you guys want to chime in, and I can add anything in the end if needed.
You don't have to when you insert them. If you look at actually the fit kit of BostonSight, the manual, it's actually laid out really nicely. It will show you that the lenses have dots on them. The right one has 1 dot and the left one has 2. And actually it also has an inscription that tells you, it says the patient's initials and what lens diameter. And it'll show you the normal pattern of where the lens ends up. And these lenses tend to go to around the same place most of the time. So truthfully, no. And in my opinion, I think this is actually a really good thing because the patients have enough to worry about when they're learning to put on a scleral lens for the first time. So getting it in at the exact dot on the exact spot doesn't have to be so stressful.
And when we do our evaluation, I always mark in the chart exactly where that dot is because that's very helpful. And it's actually necessary when you're doing any changes to the haptics. You need to know where that dot is because you need to know where the 1, 2, 3, and 4 are so you can adjust those particular parameters.
So I think you added.
So, Karen, I was going to say, when Karen had mentioned about independently changing, the different parameters, you could also independently change, all or one of those for, quad haptics.
That's right. So BostonSight SCLERA is a quadrant-specific design, and they are what Dr. Sorkin was alluding to. I think is a very good thing to highlight is the fact that all the meridians are engraved with a very simple numeric system, 1, 2, 3, or 4. So regardless of where the dot is, if the lens is aligned, you can see where if there's a haptic that you need to change, either steepen or flatten, you would go to FitConnect. There's some graphical representations that would guide you as to what changes to make in those haptics. You just find the numbering system in that haptic, that laser engraving, and that indicator would tell you which meridian you have to modify. In our clinic, we do let patients know to orient with the dots. At top, it depends on, your preference. We do recommend, start them with the dots at the top, and the lenses, as Dr. Sherman was saying, they're going to find their place. Usually they sit kind of in an oblique manner. But as Dr. Sherman was saying, if for some reason the dot does not land in the superior portion, let's say it lands in the inferior portion, and that's the scleral shape of your patient, the beauty about this numbering system is that if the lens is stable, it's not rotating, and the haptics are actually aligned in that manner, and maybe you just need to modify one haptic or the other, again, you just refer to that number that is engraved in the haptic. That will tell you which haptic, which meridian you need to change, and by which amount, and then you would do that in FitConnect. So that's a very good question. Stephen and Suzanne, how do you use topography, given that the algorithm that Suzanne just explained, it's not based on a calculation, it's not based on base curve, on topography. Basically, the way to fit BostonSight scleral is once you choose your diameter, then you just go to the standard scleral shape. This is based on data. And then from there, I think that's why, Suzanne, you probably haven't had the need to go to a steep scleral shape or flat scleral shape. But then if you do, then you just go to the right or left of the set. And so there's a question here. So how do you use topography, if at all, to guide your fittings, to help you understand what you're going to do with your patient?
I will say, we have, we're very lucky that we have the pentacam, we have tomography in the practice. I don't rely on it heavily anymore. I find that everything I need, I can learn from just doing a side profile. Not everything, but most things I can learn from doing a side profile view of the patient and from putting this diagnostic lens on. So I think my fits would be very similar even without the topography or tomography. It is helpful and it tells you the irregularities and it shows you different things and it helps you know maybe if the visual center or the optical center is probably going to be inferior. But it doesn't lead me personally in which lens I pick. And I don't rely heavily either on OCTs with my lenses. Now, I will tell you in the beginning, I did a lot more, but the more you eyeball it and the more you do, time and everything, I find that I don't need to rely on the topography or tomography as much. So I like having it. And when I work with my technician, who is my right hand fabulous, I know she references it. She always takes note of the steepest point. She always takes note of the flattest point. And for her, it gives her a guidance of where to begin. But I personally don't use it significantly.
I agree.
Okay. What I would say, for me, I would agree with you, but we use it more as a general guidance. For example, if it's a very steep protruded cornea, what that would help me is to then choose perhaps to go to a larger diameter for the reasons that you described so beautifully, Suzanne, just for weight distribution and avoid, compression over time. We actually have an attendee from Lisbon, Dr. Rodolfo Moura, who I actually met last weekend. Thanks for joining, Rodolfo. It's so nice to see you join the webinar. And you're absolutely right in your comment and question, Rodolfo. We do orient the lenses. As I said, it's advisable to tell them to orient the lenses at the top, and then they'll find their position. And then from there, then you just go find the numbers and engrave in the haptics and modify from there. We'll take one last question. We're a little bit close to time, if not a little bit past, but I think this is a good question that I think it's good to end with. Dr. Gier, I hope I'm saying your name correctly. She or he, I'm sorry, suggestions for fitting eyes with filtering blebs. Do you go smaller? Do you go larger over it? Do you use a channel? Can you both speak about your perspective, how you approach these anatomical elevations?
Yeah. Go ahead, Steve.
I was going to say, I think it really depends on the anatomy and the location and the size, and if an overhanging bleb or if it's a small, nodular one, location closest to limbus or where and how wide it is. I think that really depends on those factors.
I would say, with fitting a bleb, and most of the patients that I think I'm fitting who have blebs are usually in pretty bad shape. You have to weigh the risks and the benefits of them wearing a lens. So I have a couple of monocular patients who have blebs wearing a scleral lens. It is very challenging to fit a really small diameter scleral lens with a patient with a bleb, depending on what Steve just said, where the bleb is. Is it closer to limbus? Is it hanging over or not? Because the last thing you want is any mechanical rubbing of the lens to erode it or to cause damage to the bleb. I have used a channel before on a bleb, but my level of comfort and I watched that patient much more carefully than any of these other patients I've mentioned. And so I think that's where we come into pros lenses. I think that's where we come into impression molding lenses, maybe even using scleral, what am I trying to say here?
The freeform design?
Scleral,
scleral topography?
Yes. Yeah, I think these is, in my opinion, and just mine, these are the ones I'm very careful about, because the Bleb, having that surgery done is pretty intense. It changes the shape of the cornea, and doing anything to harm it. And that is a very good example of a patient who does have to insert their lens at the exact place that we asked them to. My response was not correct for that kind of patient. I'm talking about somebody who doesn't have any lumps or bumps and you're not using channels. And I don't think notching is really used as significantly. Actually, I remember hearing Karen speak in like 2017 at GSLS about notching. Do you remember that? Up on the stage and being so impressed by, she admitted to what we thought was right and what we realized wasn't right, which I think in scleral lenses, in any lenses, Steve and I presented 3 or 4 cases that went well, but they don't all go well. And I actually have a Bleb patient that ended up failing after being fit in a scleral. So I think that you have to use, you co-manage it with their glaucoma specialist. Someone like Karen or Manny or any of the other fitters is probably a great resource for this, but it has to be the right Bleb at the right location, and probably very flat and small.
Yeah, I would agree. So, I mean, smart channels are great because you can bolt over them. And I would agree with you. We have to monitor these patients and check the pressure and function. Sometimes with the notching, many people do notching, and notching can be a great outcome. But what I would urge all of you to be mindful of is that at times or sometimes when we make notches, the lens sometimes tends to decenter in the direction of the notch. So if you're notching for something that relies on its function, like a Bleb, and the lens decenters around that area, it could start to impinge on that filtering Bleb and may have an impact on its function. So this is why it's good to get all these education and attend these webinars so that we can learn how to manage and troubleshoot these cases. So this is what I would say about notching, and this would be a great application for smart channels, which is one other questions from our users. So with that, if there's questions that we were not able to get to because of time, we'll make sure to follow up when we send the recording for the webinar, and we hope to address the remaining questions. But I really thank all of the attendees for joining. It's such a pleasure to see that we have attendees literally from all over the world. This is a global community. And before thanking our great speakers tonight, I do want to invite all of you to join our global community. We have a Facebook Fit Group page called BostonSight SCLERAL Fit Group. We're also on Instagram. You can follow us at BostonSight SCLERAL. We're, especially in the Fit Group page, we share so many cases, tons of pearls, tips, and it's a forum for all of us to share and learn from each other. So I invite you to join if you're not part of it. And with that, thank you so much, Dr. Sherman, Dr. Steve Sorkin. What a treat. Really, it's been such a pleasure to collaborate with you. BostonSight is grateful for your participation. I'm sure the attendees learned so much from you both. So thank you so much. Have a great night. And we will see you at the next BostonSight SCLERAL Practitioner Learning Series. Have a great night, everyone.